University at Bentani Hospital Alumni Association. It is the third one of this type, and it is under the Asian Congress of Neuro Nursing, ACNN, and kindly. Um, Let me welcome you all at this very informative webinar. And I'm very happy to have a lot of people in the panel right now, and everyone is open to join us and attend the webinar that is one of its kind in the way that it is interactive and you can join us from wherever you are. I'm Dr. Nurul Huda Maria. I'm a resident neurosurgeon from Pakistan and a young neurosurgeon as well. And it is a huge matter of huge honor and pleasure for me to host this seminar for all of you. And being a part of the ACNS, it is something that is very important and very precious to me. And I will be pleased and I will be honored to welcome Professor Alberto Filati, who is Associate Professor in the University of Verona in Neurosurgery. Sir, thank you so much for joining us today.
Thank you for the kind invitation. It's a pleasure to be here and join you.
Thank you so much, sir. It's a huge honor for us to have you here. Sir, can you kindly open the webinar with your opening welcoming message, sir?
Yes, sure.
Thank you.
It's a pleasure to be here, not only for the very informative meeting, but also because I can see again many friends from all over the world. As I was mentioning before the official opening of this webinar, this is the second Fujita Bantane Hospital neurosurgical webinar. The first one was held 1 year ago. As part of the Alumni Association from Professor Kato's institution, I want to express my gratitude to the organizers of this webinar because it perfectly matches the aims of our association, which is not only gathering former fellows and current fellows, but it's also about sharing knowledge, sharing experiences in our neurosurgical field. I think this kind of events are very useful to accomplish this mission. So thank you very much and welcome to all participants and panelists.
Thank you so much, sir, for the very nice words, sir. Indeed, it is a huge honor for us, and especially for the young neurosurgeons, to have the privilege of talking to you and interacting with you, sir. It is a huge thing for us because, especially for the developing countries, so it is usually very hard for us to learn more and more because the sources are limited, because exposure is limited. So, being here in the web and the web conference, so it is a huge honor for us. And sir, I'm very pleased that I've presented with you as a moderator as well at ISMIS 2019, and it was something very important to me. And I wrote down all the points you just pointed out in the presentation, and it was a huge learning experience for me as well. So thank you so much, and I'm
Thank you.
honored to have you here. Thank you,
Thank you.
sir. The second presenter we do here is Dr. Yujian Lau. Dr. Yujian Lau, are you online?
Yes,
Hello,
hello
sir.
everyone.
Thank you so much, sir, for joining us here. It's a huge honor. Sir, you are going to present a tailored bypass based on blood flow direction in MCA territory of MMD. Sir, it is your topic on Moyamoya's disease, a tailored bypass based on blood flow direction in Moyamoya's disease. Sir, can you kindly proceed with it?
Okay, thank you.
Thank you, sir.
Yeah, thank you.
So Professor Lau will be presenting a tailored bypass based on blood flow direction in middle cerebral artery territory of the Moyamoya's disease. Sir, thank you for sharing your screen. Thank you.
Okay, can you see my screen?
Yes, sir.
Yeah.
Yes.
Hello everyone. It's great honor for me to be here, and I've seen many old friends. And as you can see, I've just in a short break in 2 operations and 10 expressions. And today my topic will be tailored bypass based on blood flow analysis in middle cerebral artery territory in Moyamoya disease. And my name is Yujun Liao, and this is my colleague.
Hello, everyone. I'm so pleased to be here with you on behalf of Professor Binshu and my senior, Dr. Liao. I need to thank you for inviting us to join this webinar. My name is Mohammed Hilmi. I'm a master degree student here at Khwashan Hospital, and so happy to be with you here today.
Thank you so much, Dor. Yes.
Yeah, and firstly, a short introduction of ourselves. And this is where we are from. And we have 3 campus in our hospital, and we come from a huge family. And we have about 150 neurosurgeons in one single department. And we from Shanghai, China. And this one, can I see?
Yeah.
This one is our boss, Professor Xu Bing, and we are with idols all around the world. And this is when we celebrating 9 cases of Moyamoya bypass in one day. And now I will begin my topic. And it's common sense nowadays, and cerebral revascularization is the only effective way to treat Moyamoya disease. And we will be very glad to see the result, and we can see the STA is getting larger, and which can perfuse almost the totally MCA territory. And sometimes the diameter of the STA can increase to more than 3 millimeters, and this is good result. But we will be very disappointed when we see this kind of follow-up. As you can see, the bypass is patent, but with shrink STA, and of course, if clinical effect won't be so good. But why there are difference between these 2 kind of patients, and how this happened, and how to get a good result in STA MCA bypass. And we working on this topic several years, and nowadays we figure out maybe there's 2 important things during the operation of STA MCA bypass. And the first one is to perform the anastomosis. And after open the dural, we can see several artery which may be candidate for anastomosis, but which one would be better? So this is the first question. And the second question is, if we select a recipient artery, but in which direction is better? Like this patient, blood flow comes from proximal to distal. But this, so which direction should we perform the anastomosis? So I will talk about these two things next. And now let's go to the first one. After we open the dural, where to anastomosis? And let's take a short look at the equation, Pursue law in the left side. And it seems very complicated. We only need to know 2 things. The first one is the Q, means the blood flow in the STA. And the other one is the delta pressure. And delta pressure is the distance between the donor artery and the recipient artery. And as you can see, the delta pressure is the only thing we can control in the operation. And the delta pressure is the only driving force of the blood flow of the STA. So we believe during the operation is the key point to make sure the delta pressure is positive, and the delta pressure, the higher the better. And it's very complicated to talk about hemodynamics. So let's talk about real case in the operation room. And When I was the operator, after open the dural of this patient in the right side, which is angiogram, and I confused B point and A point. Which one is better for anastomosis? My boss told me the A point would be better, but why? And he said point A can make a bigger and larger delta pressure, but why? Let's see this. And still this patient from B point to A point, and the pressure distance on A point is equals pressure of STA minus pressure in A point, and similar to B point. So because the A point is in the downstream of the blood flow, so the pressure in A point is smaller than pressure in B point. So we speculate the A point would be better for anastomosis, but this is a hypothesis. So we conducted clinical research, and it's like this. In a case series, we performed double-barreled bypass. As you can see in the left side, double bypass in both A point and B point. And this is the chunk of STA, and we place a detector in the trunk of STA. And after we occluded the A point, we can measure the pressure in B point. And in the other way, we can measure the pressure in the A point. And in this way, we can measure the pressure in A point, B point, and the pressure of STA. And it's very complicated, but the result is interesting. As you can see, A point is in the downstream of the MCA blood flow, and the pressure is about 21, and the B point pressure is about 36. So the clinical study confirmed our hypothesis, and actually it's true. A point, because it's in the downstream of MCA blood flow, so it's better for anastomosis. And this is our clinical research. And but as you know, in Myomes disease, not everyone got this blood flow direction. In some cases, we can see blood flow direction with retrograde direction, like this one. Since the MCA is totally occluded, so the MCA territory was perfused by collaterals from posterior circulation and sometimes from ACA. So in this kind of patient, the B point will be the downstream of the blood flow. So the B point in the right side will be a better choice for anastomosis. So this is the first part of my topic today. Recipient artery in downstream of MCA blood flow is better for anastomosis. Now we know where to bypass, and the second question is how to bypass, how to select the direction of the bypass. And this is a picture by Professor Benkoch from Germany, and he already talked about the blood flow direction and its common sense according to basic physics knowledge. And we should make the bypass flow and initial flow in the same direction. That would be better. But is it really true in the real world? We also conduct a retrospective study of our early cases. And we enrolled about 50 myeloma cases around 10 years ago. And these are these are our early cases, and after chart review and review of the angiogram, we divided the cases into two groups, and one is co-direction and the other is counter-direction. The co-direction means the bypass flow goes in the same direction with the initial blood flow in MCA territory, and the counter-direction group means the bypass flow goes in the opposite direction of initial blood flow. And we analyzed the clinical result, and we find the co-direction group during the early follow-up and the 6-month follow-up. The co-direction strategy can get a higher blood flow of the STA and with lower resistance of the STA. And so the co-direction group will have a lower risk of a transient neurological deficit and the lower incidence of watershed shift in ICG video angiogram. I will show you angiogram in our operation. As you can see, there's blood flow competition in this area. And we can observe this kind of phenomenon more often in counter-direction group of patient. And during time, we will skip this part. And we also performed a long-term follow-up with angiogram, and the result is that the co-direction group will get a larger STA and a larger feeding area compared with the counter-direction group. And this is the typical follow-up angiogram of counter-direction group. We can see the bypass is patent, but the blood flow is not so good. But in the co-direction group, we can find the blood flow very well, which can perfuse almost all of the MCA territory. So this is our conclusion, and how to get a good result during the STA-MCA bypass. And the first one is to weld to bypass. And our conclusion is that recipient artery in the downstream of MCA blood flow is better for anastomosis because it can provide a larger delta pressure. And the second question is how to perform the anastomosis. So our conclusion is that we try to make the donor artery and the recipient artery in the same direction. So this is our conclusion of this topic.
Thank you so much, sir.
Thank you very much.
Thank you so much, sir. The honor is huge, sir. Thank you for addressing such an important topic, especially for us in many parts of the world. Moyamoya disease is not very common, so most of us do not even have a very good idea of about even the surgical options. So thank you so much. And this presentation is very important about the recipient artery selection. It's actually it actually has a huge impact in the long run, since you know it is the long prognosis is dependent upon the initial you know the initial selection of the artery. So thank you so much for addressing this very important topic for us.
Thank you for your comment.
Yes, so it's huge that you have actually correlated. Thank you so much for addressing this very correlated physical and the dynamic hemodynamics of blood with the selection. Yes, so it's huge that you have actually. Thank you so much, sir. So, any questions from our panelists? Or kindly share any questions if you have.
Good evening, sir. What do you mean by downstream? Do you mean distal MCA? What does
Yeah.
downstream mean?
Yes. Thank you for your question. Hi. Do you mean what we
You said,
define the downstream or upstream?
yeah. What do you mean by downstream? You mean to say it's a distal MCA branch you should select? What do you mean by downstream?
Yeah,
For
I know. Thank you. Can you see the slide PowerPoint? Yeah, for take this patient, for example, and we can see the MCA is almost occluded, but the blood flow still goes from proximal to distal. It's like it's just like this normal anatomy, and so the blood flow goes here from here to here, and the proximal is so-called upstream, like a river, and the distal part is so-called downstream. So we speculate the pressure of the proximal is higher than distal because the blood flows from the proximal to the distal. Just think about it as a river, and the how to say, imagine this as a river. So the distal part here is like downstream of a river. So the blood pressure will be lower.
So M4 is better than M2, you mean to say? So for anastomosis, M4 is better than M2.
Not M2 or M4. We use the recipient artery in temporal or frontal lobe.
Sir, what I can understand is that it is about it is according to the Bernoulli's theorem, where the P1 V1 is equal to P2 V2. That is, the change in pressure is equal to the change in the velocity of blood. So I guess it is about how much change that how much there is a difference in pressure from the proximal to distal. So if there is a huge difference in pressure between the proximal and distal, then we should just try to select the distal one so that the blood keeps on flowing towards the distal end. Like if we just add the proximal end where the blood is going to flow, we are going to obstruct it later on. So according to Bernoulli's theorem, the distal end will be the better one, the ideal one. That's, I guess this is the point.
Yeah.
Yes.
Let's take this patient as an example. Just take the frontal lobe and ignore the temporal lobe. This patient, the frontal lobe blood flow comes from B to A, and imagine this as a river. So the A point is the downstream of the river, so the pressure will be lower than B point. So in our opinion, the A point will be better for anastomosis.
So that the blood flows towards the side that is of lower pressure, so that we are just not going to interrupt the flow. That's right, sir?
Yes.
That's how we are going to just make the flow towards the normal downward side. If we just implant it over the higher side, that we will be obstructing the blood flow. That's, I guess this is the point which we want to know. So this is wonderful.
Thank you.
Thank you so much, sir. Thank you so much for your time, and thank you so much for your question as well. Can we proceed towards the second one? The third one is again, Sir Professor Alberto Filetti. May I request you to kindly share your very kind topic on endoscopic in vivo ventricular anatomy?
Maria, excuse me. I'm talking with Alberto by message. He's got a problem with his internet connection. So he asked to go to the next presentation until he could fix.
I think the fourth one is actually by Dr. Kadam Chandra Taj.
Yeah.
This is yours, yes? So, okay, sir, you are going to share our experience with keyhole endoscopic surgeries.
Myself, Dr. Chandratej Kadam. I'll be talking today on our experience of keyhole endoscopic surgery in skull-based lesions. So using keyhole approach, we can produce excellent results in terms of less brain exposure, shorter operation time, and shorter hospital stay, and better wound scar. So we are presenting 5 different skull-based pathologies managed by a keyhole approach. This is a first case of trigeminal schwannoma. We manage this by endoscopic subtemporal interdural approach. So this is the pre-op MRI image showing the trigeminal schwannoma or right side, and this is the post-op.
Kindly, sorry, excuse me, your slides are being not changed. Kindly, just give a look to your slides, please.
Okay, okay.
Yes.
Why? Wait 1 second.
Yes, sure.
We try. Okay, you see?
Yes, right. Thank you.
Why impose? Yeah. Okay, try again.
No, it's okay. Isn't it moving? You know, is it stuck?
Moving?
No.
No.
I don't know why, but it's going to stop automatically. Well, here you can see. Now you can see.
Yes.
Try to use the F5 button. Try to use the F5 button instead of the tab. Use the F. Can you please use the F5 button?
Yeah.
Yes.
No.
Instead, and just move the arrows. Move the arrows. Use the F5 button and move the arrows.
Do it again. No. Okay. You can see?
Yes, please.
Yes, it's okay. So using keyhole approach, we can produce excellent results in terms of less brain exposure, shorter operation time, and shorter hospital stay. So we are presenting 5 different skull-based pathologies managed by keyhole approach. So this is the first case I'm talking, trigeminal schwannoma. We manage it by endoscopic subtemporal interdural approach. So this is a pre-ops MRI. You can see a right trigeminal schwannoma, and this is a post-op image showing a complete excision. So we followed the following steps during the operation. First was the peeling of the temporal dura, then the MMA identification, then the interdural incision and the tumor exposure was done. The tumor decompression was done, and then we can see the tumor cavity, and this is the image after the hemostasis. Second case we did was the petrous apex meningioma. This is the pre-op CT, and this is the 3D fusion image showing the petrous apex meningioma. This you can see very well in the MRI image also. So we proceed this case with the endoscopic subtemporal intradural approach. So we first did the retraction of the temporal zone, then the coagulation of the petrous dura, then the tumor decompression was done. You can see the tumor cavity here, and the fourth nerve and the tumor part, small part which was adherent, was left behind. So this is the post-op CT and MRI showing the complete excision of the tumor. The third case we did was a cleval fibroma. We managed it by endoscopic endonasal approach, and we did the following steps: the mucoperiosteal separation, followed by exposing the sphenoid sinus, then clival draining, and the cleval dura was exposed, and then the tumor removal was done. So fourth case we did was a cerebral cavernoma, and it was managed by endoscopic supracerebellar infratentorial approach. This is the pre-op CT. You can see a cavernoma in the vermin region, and this is the post-op CT showing the excised part. So the first did was the cerebellar corticotomy, followed by the dissection of the cavernoma. Then the cavernoma was removed. This is the cavity showing the cavernoma, and then the reconstruction was done. Fifth case was the interesting one. It was a Meckel's cave meningioma, It was managed by endoscopic retrosigmoid approach. So this is a pre-op MRI showing the Meckel's cave meningioma, and this is the post-op MRI showing the complete excision. So actually in this case, we dealt with the two pathologies. One was this meningioma, and the patient also had a symptoms of trigeminal neuralgia. And as we can see in this 3D fusion image, there was a neurovascular conflict at the superior cerebral artery. And the meningioma was also compressing the fifth nerve. So we did a CFD for SCA, and this computational flow dynamics of this vessel showed the significant changes at the neurovascular conflict points, as you can see in this image. This is the intra-op image. We can very well correlate with the CFD image. So this was the contact point of the SCA loop with the fifth nerve. And in CFD vector changes, you can see this was the hotspot. So this was the intraoperative video of the same case I'm showing now. We did a retrosigmoid keyhole craniotomy, and then this is the intraoperative view. You can see the tumor, the SCA loop, the fifth nerve. The tumor dissection is being done. The last part of the tumor was removed, and then after the complete tumor removal, we identified the neurovascular conflict. Then we did the transposition of the SCA loop, and it was fixed by the glue. Next. So while comparing, we can say, to keyhole approach and open surgeries, it has many advantages like small surgical incision and small craniotomy, better visualization in a narrow corridors, less post-operative complication, and shorter hospital stay. And to conclude, we can say keyhole approach is the most advantageous due to its effectiveness in selected skull-based lesions based on the lesser brain retraction, best visual fields, even in the narrow corridors and deepest surgical fields. Thank you.
Thank you so much for sharing your very nice presentation with us. It's a very important point, especially providing this new scenario where most of the surgeries are keyhole. So thank you for sharing your approach. Any questions? Hello, any questions?
No.
Thank you so much for sharing this. It's a very important point, and I would like you to again, when you present, then add the videos as well, because it is very informative. The pictures are very good, but if you add the video, this would be huge. And thank you so much for basically addressing this very nice presentation and addressing the very important surgical problem, because most of the time people are basically comparing whether the endoscopic approach is safer or not. But I guess it is in the end, it is basically depend upon the expertise of a surgeon and basically upon the competency level of that surgeon to conclude the surgery in this much efficient way. So thank you. And if you are able to do so, it would be very good.
Thank you. Thank you for the opportunity.
Thank you. So next is, I guess, Professor Alberto Filati has got his offline right now. So can I request Dr. Gautam to present next? Is he here? Yes. Thank you. So welcome, sir, to our panel, and share your lecture on KINEVO.
Yeah.
Thank you, sir. Thank you so much, sir.
Can you see the video?
Yes.
Are you able to see?
Yes.
I'm going to just speak about few uses of KINEVO 900 in vascular neurosurgery, and it has been proven very good. And this is the robotic visual system with a surgeon controlled robotics and advanced ICG along with digital hybrid visualization. And with Kinevo 900, the surgeon is able to electrically move all the 6 axes provided by the foot control itself, so that he may not remove his both the hands at the while doing surgery. And you can see there is autofocus on the foot switch and along with XY joystick, and followed by fluorescence on the right side and XY axis and position memory. In this Kinevo 900, we have this horizontal point lock and position memory as the 3 new features which was given. I will be demonstrating each and every thing. This is the position memory.
No, it's not getting.
Here we can store multiple positions on pressing of a single button. We can bring the microscope to required position. You can see when the surgeon, when the field is out of field with a single point, automatically the microscope comes into the position and surgeon immediately can peep inside. This is only a demonstration and its use can be seen in this. Here the surgeon, you can see the surgeon is viewing in the endoscope while explanation, and then on positioning immediately microscope comes in and patient was able to see the perforators exactly and coincide the anatomy, because of which it was very user friendly at this. The other XY swivel movement, we can see this is the movement where it is mostly present in all recent microscope, and with this function the surgeon can focus immediately to another point of the same focal length. You can see the movement in the screen of the where there is movement to the next focal point. And this is the XY horizontal point. Especially this function is useful when there is area of interest. When you are zooming in or zooming out, it may be going out of field. So this is a very simple where there is minimal movement. You can see it is out of focus here, and then with that simple horizontal movement without losing any point, without any touching of the microscope, it was easily focused. And this is the point lock function, which is very important. Here there will be a one point which is already locked, and after which when the surgeon is having difficulty in using both the arms with the instruments, he can change the field, outside field, but not that point of interest. It can be demonstrated. This will help the surgeon. You can see the point is not changing here. And this is and the other important function is the digitalization and software in which we can use the ICG along with Flow 800. You can see this is another case of aneurysm where there is anterior choroidal artery is behind, and it is easily demonstrated on ICG. With the advanced ICG, you can see that very small vessels also been perforator can be seen, and even in the ending, you can see the flow which is in the bleb, still persistent of the flow. And this is the advanced Flow 800. You can see the pre-clipping. This is the aneurysm. We can see the total significant flow, and this is post-clipping. There is completely loss of flow in the aneurysm. And this is another demonstration of a case of basilar aneurysm. You can see the basilar aneurysm, basilar artery, basilar aneurysm, and superior cerebral artery and third nerve. And this is the ICG. You can see the ICG flowing. And after this patient underwent clipping of the aneurysm. This is one clip applied. You can see it is not fully occluded, and there is leak of the flow into the aneurysm. This is the point where we have to differentiate there is a leak. So the flow dynamics also confirm there is still flow is there in the aneurysm. So next we applied the second clip. So after second clip, there is still some dye present in the aneurysm. Whether it is because of residual or filling of aneurysm, we need to find out. So in this scenario, the flow 800 is very useful. After flow 800 confirms there is no flow in the aneurysmal sac. So with the advent of advanced optics and robotic, KINEVO is a surgeon-friendly microscope, and minimizing time for a very small adjustment, especially this may be finding helpful when there is a aneurysm rupture or something like that, and with a great accuracy in visualizing the vascular structures. Thank you very much. Thank you for.
Thank you so much.
Yeah.
Thank you so much for sharing this very important slide. Any questions from the participants?
No. No.
No. Okay. Thank you so much, sir, for this introducing this very important device. This is actually very helpful in neurological surgery. Thank you. So can I request Dr. Riccardo Stanzani? Is he here?
Yes, I'm here.
Yes, thank you for joining us. Dr. Riccardo Stanzani, will you kindly present your presentation on recurrent aneurysms after surgical and endovascular treatment, a single center experience? Thank you.
Okay. You can confirm that you can see my screen?
Exactly, we can. Everyone
Okay.
can see? Yes.
Yes, okay. Good evening to everybody. I'm here to introduce to you Bantane Hospital experience in treatment of recurrent aneurysm. Before doing this, we just a briefly reminder of the type of treatment for intracranial aneurysm, microsurgical clipping, better preferred for young patient and wide-necked aneurysm, and endovascular treatment preferred for narrow neck aneurysm, agdom to neck ratio aneurysm, and in patients with several medical comorbidities. In the literature, you can find several data about recurrence and the reerupture risk. What we know for sure is that the degree of aneurysm occlusion after treatment was strongly associated with the risk of reerupture. We can see in this study from Roy et al., where they evaluated the microsurgical treatment after previous endovascular therapy, most of the patient after SA. They evidenced that initial presentation grade, age, and aneurysm size are predictor of final patient outcome. Lawton's group analyzed the risk factor for retreatment of previously cold aneurysm and found that aneurysm size greater than 8 millimeters, wide neck, low aspect ratio, posterior circulation aneurysm, smoking patient younger than 52 years old, and ruptured aneurysm correlated with high risk of retreatment after endovascular procedure. And in this paper, it is very interesting to consider the consideration about protruding clip, like in the picture. If the clip are protruding, they can complicate microsurgical clipping because they can causing the slip down of the clip. Another study from Cohen-Gadol group studied evaluate the incidence of recurrence after microsurgical clip ligation, and finding that incomplete exclusion and multiple aneurysm evident at presentation required closer long-term follow-up because an incomplete excluded aneurysm have a risk of recurrence from 0.26 to 0.53% per year. Another interesting paper is this one by Gross et al., where they evaluated the endovascular treatment of previously clipped aneurysm, finding that endovascular treatment could be excellent in a well-selected kind of patient, introducing this concept, the clip-induced narrow neck, where the clip narrowed the neck and could facilitate endovascular treatment. Okay, after this brief review of the literature, we are going to consider Bantane Hospital experience. 4 years, 557 aneurysms treated by microsurgical clipping, 112 treated by endovascular treatment. And in this series, we found 5 cases of retreatment after microsurgical clipping and 6 cases after endovascular treatment. In this table, we can see the data about retreatment after surgical clipping, and in this one, retreatment after endovascular procedure. Let me see some cases. The first one, a man with unwrapped left MCA aneurysm, previous treatment with surgical clipping in 2012. After the treatment, a recurrence with slow increase. So new surgical clipping. We can see the intraoperative video, the aneurysm with endoscope check, ECG check with a good flow into the aneurysm. A multiple clipping was performed to obtain a complete occlusion that you can check later with the ECG, as you can see, and also with endoscopy to evaluate perforators. This one is the 3D reconstruction after post-op CT angio. Second case, giant vertebral artery aneurysm treated multiple times with endovascular technique and surgery. Patient present progressive diplopia, left fascial weakness, dysarthria and dizziness as symptom related to increasing size of the aneurysm with significant compression of the brainstem. So we decided to perform surgery. You can see here some intraoperative images. Giant vertebral artery aneurysm with dilated vasa vasorum, expression of a wall disease. Doppler and endoscopic check during the surgery. Aneurysm was opened and trapped with the removal of the coils and the thrombus to reduce mass effect. Third case, unwrapped anterior communicating artery aneurysm, clip with pterygium approach in 2015. 3D reconstruction after postoperative CT angio show us an important residual of the aneurysm that was treated again in 2017 with interhemispheric approach. We can see the intraoperative video, old clip, and the aneurysm residual. Pre-clipping ECG was performed, and then we start to clip. Multiple clip is needed. One, the second one. And after ECG, we can see a small residual here, so we decide to put another clip to complete the occlusion. And we finish surgery, clipping also another aneurysm from a distal ACA branch. This one is the post-op CT angio with the 3D reconstruction. Next case, incidental unruptured distal ACA aneurysm. We can see the patient was treated 2 times with coiling, one in 2008 and one in 2009. This DCA follow-up showed a neck recurrence in 2015. So we decided to perform surgical clipping by interhemispheric approach. We can see the intraoperative video, the aneurysm with the coils inside it, neck patency at ECG pre-clipping, clipping of the aneurysm, and post-clipping ECG that confirmed the complete exclusion of the aneurysm. And here we can see the 3D reconstruction after post-op CT angio. Fifth case, right MCA and ICOM-A aneurysm treated by coiling in 2005. During the follow-up, we can see a recurrence about both of the aneurysm. So we decide to perform surgery. This one is ICOM-A aneurysm with coils and ECG pre-clipping. One clipping is good to exclude the aneurysm. This one is the MCA aneurysm, the good flow on the neck, and two clip are needed here to complete the exclusion, 1 here and 1 here, and we can see the final ECG check, the good exclusion of the aneurysm. Also, in this case, we've got post-op CT angio with 3D reconstruction. Last cases, one patient of few days ago, an old female with a Picome aneurysm treated by coiling, neck recurrence on the follow-up, and we can see the post-operative video. We identified the aneurysm with coils, perform pre-clipping ECG, neck recurrence here, and clipping with a good post-clipping ECG. So our result in this small series, we didn't see morbidity or mortality, and also no bleeding or rebleeding. It's a small series, so we have got only few take-home message, nothing else. Recurrence could happen after both type of treatment. Giant thrombosed aneurysms are a whole disease pathology and needed to be treated in a different way than other aneurysms. High volume center ensure good outcomes, and maintaining expertise is important to maintain good outcome. Thank you very much for your attention.
Thank you so much for sharing your slide. It's a very important topic, and we can easily conclude that if properly selected, the endovascular and endoscopic approaches can be basically depend upon the proper selection for mortality and morbidity. Thank you so much for sharing. Any question? I guess if there is any, kindly let us know. No? Okay, so can we proceed with the next? Can we proceed with the next one, please? Can I kindly request Dr. Vaibhav Chama? Is he here?
Yes.
Thank you, Dr. Vaibhav Chama, for joining us. Can you kindly share your informative slide on Flow 800?
Yeah, good evening, everybody. This is Dr. Vaibhav Chauhan from India. I'm currently doing the fellowship in cerebrovascular surgery at Fujita. I'll be talking on use of Flow 800 in the vascular neurosurgery. So basically, what is Flow 800? Flow 800 is a mathematical software tool which is installed inside the Zeiss microscope Kinevo. So Flow 800 is the unique analysis tool generating the blood flow dynamics data by identifying detailed vessel blood flow from the infrared 800 video sequences intraoperatively. So how it works, principle. ICG, when it is present in the blood vessels, when NIR light source from the microscope illuminates the ICG, NIR sensitive camera captures the fluorescent light emitted by the ICG. Fluorescent light video generated from the ICG is analyzed by software Flow 800. Software does the movement correction automatically. Changing ICG fluorescence is color coded with respect to the time. Flow 800 then generates intensity, delay, speed, color diagrams depending on the temporal sequence of the appearing fluorescence at a particular region of interest. And the graphic analysis of the data is done by the Flow 800. This is the Flow 800 in Pentero and Kinevo. In Kinevo, they have added one more function. In Pentero, there was a delay, intensity, and then there was a histogram. In Kinevo, there is a delay, intensity, and speed, and the histogram is shown as in the figure. This is a normal ICG. You can see, you cannot identify which one is the artery and which one is vein on normal ICG. But with Flow 800, it generates a delay map. It automatically color codes artery with the red and vein with the blue. And it provides the quick information about the time when a fluorescent signal appeared for each image point in the map. This one is the intensity map. Depending on the intensity, it enables you to conveniently identify relative fluorescence level reached during the infrared Flow 800 observation period. This is speed map. So the speed map indicates how fast the fluorescence intensity is increased during the observation period, indicating the speed of blood flow. So coming to the clinical applications of the Flow 800 during AVM surgery, you can see this is after doing a craniotomy, you can see AVM here. You can see this is a ICG. On ICG, you cannot say which one is the artery, which one is the draining vein. You cannot say, but the Flow 800 generates the picture something similar, something like this. Here, this one is the feeding artery by red, and this one is the draining vein. So it will definitely help you in the complete excision of the AVM. Yeah, Flow 800 is useful in the aneurysms also. So this is a preoperative image of the aneurysm, ACOM aneurysm basically, and this is the intraoperative Flow 800 image generated by the software. You can see here is the aneurysm. This is the region of interest, and you can see the graph. The graph is rising. That means the aneurysm is filling by the blood. Once we clip the aneurysm, after clipping we done a Flow 800. This is the region of interest. This is the region of interest. You can see the graph is flat. That means there is a complete occlusion of the aneurysm. So it helps. This is a intraoperative video demonstrating use of Flow 800 in ACOM aneurysms. You can see. This is a preoperative image showing the ACOM aneurysm. Now we are doing a surgery. Now you can see the aneurysm. This is the aneurysm. This is A1, this is A1, contralateral A1, this is aneurysm. This is the endoscopic view, this is ICG. And because of atherosclerosis, ICG is slightly dampened, you can see. But with the Flow 800, aneurysm is filling, graph is rising. Okay. Then after we applied a first clip, because of the atherosclerosis, you cannot make whether there was there is a residual filling or not. But after Flow 800, it was confirmed that there was a residual filling. So we applied a second clip. Post-clipping ICG show complete occlusion of the aneurysm. And post-clipping Flow 800, you can see this is the region of interest of aneurysm, and there is a complete flat graph showing the aneurysm occlusion. So scenario where Flow 800 can be useful, very useful. This is the scenario. You can see this is the arterial phase of the ICG. There is no filling, but in the venous phase, there is a slight filling. So there are two differential of this venous blood. Either it could be a residual dye or it could be an incomplete clipping. So Flow 800 can be very useful in this scenario. If you put a region of interest in this venous filling and analyze it, if it is a residual dye, then there will be a flat line. If there is an incomplete clipping leading to filling of this aneurysm, then there will be a rising graph. That way it helps. Then Flow 800 is also useful in the vascular bypass. You can see this is a proximal artery. This is a distal artery bypass. This is the site of bypass. We have done a Flow 800 analysis. The region of interest in the distal artery, it is showing up flow. So in this way, you can confirm the patency of the bypass by Flow 800. So apart from this, the semi-quantitative data generated by Flow 800, you can use it for the prediction of perfusion status of the brain. You can use for the prediction of hyperperfusion syndrome. You can predict vasospasm with the Flow 800. Even there are clinical research done. You can predict a vasospasm with the Flow 800. You can demonstrate the direction of blood flow before bypass, which can determine the need of bypass. But there is some restriction. We cannot use semi-quantitative data with confirm because its reliability is not yet proven. I mean, more studies are needed. It can give you idea about the trends. So here, this way this picture shows you how you can predict the direction of the blood flow. This is the proximal side. This is distal side. So after doing a fluid 100 analysis, the proximal blood for the blood to reach at the proximal site, it takes 1.1 second. For blood to reach at the distal side, it takes 2.1 seconds. So that way you can analyze the direction of the blood flow on fluid 100. So next.
Good.
This is a semi-quantitative fluid 100 parameters. Every time it generates a graph, there are parameters like on x-axis there is a time. X-axis there is a fluorescent intensity. On y-axis there is a time. And there are these semi-quantitative parameters like arbitrary intensity, cerebral blood flow index, rise time, t-half max. So what is the after limitations of fluid 100? If the vasculature is not in the surgical field, fluid 100 or ICG is not useful. There is a waiting time of 15 minutes between the two injection of ICG. 1 minute is required to generate the maps and flow chart. Till that time, surgery has to be stopped. Semi-quantitative data generated has limited clinical usefulness and more studies further needed to confirm the validity of this data. If vasculature is covered by the hemostatic material, accuracy of the fluid 100 is reduced. So to conclude, fluid 100 is very useful tool in the vascular neurosurgery. Thank you very much.
Thank you so much for your very nice presentation. Is there any questions from the participants?
No.
No. Okay. Thank you so much. Professor Alberto Falati is here again. Thank you so much, sir, for joining us again and for the extra favor that you had to do. Sir, would you like to please share your lecture on endoscopic in vivo ventricular anatomy?
Yes, sure. I'm sorry for the inconvenience, but probably the connection at my hospital doesn't work so well. So I had to go back home. Hopefully now I will have no problems. Can you see my screen now?
Yes, exactly.
Okay, so I was asked to talk about the anatomy, endoscopic anatomy of the ventricular system in vivo, which is something I think very important for all neurosurgeons who want to perform any procedure with an endoscope inside the ventricles. We always need to understand and know anatomy first. And nowadays it is possible to explore almost every corner of the 4 ventricles of the ventricular system. And we can do that because we can use a flexible endoscope. Of course, with a rigid endoscope, you have a very nice view and good quality images of the lateral ventricle and of most of the 3rd ventricle. But with the flexible scope, you can move everywhere. And this is possible because it perfectly adapts to the complex and irregular geometry of the ventricular system. So let's start with the lateral ventricles. The first structure you see after entering the lateral ventricle is, of course, the Monro foramen with the columns of the fornix here. And you can see, of course, the choroidal plexus running on the floor of the lateral ventricle and the thalamus striate vein here, which is covered by the lamina affixa thalami here. And if you follow the choroidal plexus and the thalamus striate vein, they lead you directly to the Monro foramen. You can also see the septal vein here and the septum pellucidum here. Of course, if you bend the tip of the scope all the way to the back part of the lateral ventricle, you can also inspect the occipital horn. But if you enter the Monro foramen, the first structures in the 3rd ventricle you can see, of course, are the mammillary bodies here. And in front of the mammillary bodies, the tuber cinereum, which is the area where we perform 3rd ventriculostomy, as you all know. If you move your scope even further, in front you can see the infundibulum, the optic chiasm, and the lamina terminalis. if you move the scope to the back part of the third ventricle, like we are doing here, the adytum of the cerebral aqueduct appears, as well as the posterior commissure, the pineal recess, the habenular commissure. This is the suprapineal recess, and in some cases we can also inspect the roof of the third ventricle with the choroidal plexus, and this is the internal cerebral vein. And in these two left bottom images, you can see a very interesting and unusual anatomy of the anterior part of the third ventricle, which I inspected in one case through a fourth ventricular approach from posterior fossa. Here you have a very nice view of both Monro foramina and the triangular recess and the anterior commissure. With the flexible scope, if the aqueduct is not stenotic, like in this case, you can explore the cerebral aqueduct and you can see all 5 parts of it. Of course, the adytum, as we have seen, but also the first constriction, the ampulla, which is this enlargement in the middle part of the cerebral aqueduct, and the second constriction here, and the egressus, which leads you, of course, inside the fourth ventricle. In the fourth ventricle, there is a number of structures. You can clearly distinguish the choroidal plexus above the cerebellum here. This is, of course, the roof of the fourth ventricle, and you can also explore the floor of the fourth ventricle, which is the brainstem. Here, you can see the facial colliculi, this and this. But if you move the scope even further towards the inferior triangle, you can see these. These are the acoustic striae. And in some cases, you can see on the floor of the fourth ventricle, even the vagus and hypoglossal triangles. If you go even deeper into the fourth ventricle, you can get to the inferior triangle of the fourth ventricle, like we are doing right now. This is the canalis centralis medullaris here, and this is the area of the obex. Here we are exploring the right Luschka foramen with its choroidal plexus. And here you have the Magendie foramen down here. We can see it here in these pictures on the left part. You can also see in these pictures the pica. In some specific cases, we intravenously inject fluorescent sodium to have a clearer vision of, for example, some intraventricular tumors we want to do a biopsy of. But in normal anatomy, this fluorescent sodium highlights something that would be otherwise invisible, like this tiny subependymal vascular network. And as you can see, with normal light, you are not able to clearly distinguish this thin vascular network. But with the fluorescence, this vascular network becomes very clear. But probably the most intriguing application of fluorescent sodium in intraventricular endoscopy is the one referred to the possibility to visualize some of the circumventricular organs. In this patient, here we are at the level of Monro foramen. Of course, this is the choroidal plexus, as you can, of course, see. This is the third ventricle with the mammillary bodies. Here, tuber cinereum. Nothing is visible, but with fluorescence mode, the median eminence appears. And this is the organum vasculosum laminae terminalis, which you cannot see with normal light, actually. So I think in the case of the median eminence, this circumventricular organ at the level of tuber cinereum, it's very interesting to think about it, because that's the place where we do the third ventriculostomy, thinking that no function is in the tuber cinerarium, and actually some function is present also at the level of tuber cinerarium. Now we are moving inside the fourth ventricle, and also in the fourth ventricle we can distinguish a circumventricular organ here. This is the area postrema. See, here we are at the inferior triangle. This is the canalis centralis medullaris. Here is the obex. With normal light, you cannot distinguish this circumventricular organ, which is important for example, vomit or hiccup. But with fluorescence mode, you can clearly distinguish this circumventricular organ like two leaves diverging from the central medullary canal. So to conclude, flexible endoscopy allows the vision of the anatomy of the ventricular system from a very new perspective. And we counted at least 47 anatomical landmarks inside the fourth ventricles. And with fluorescence, we are able to visualize some structures that would be otherwise completely invisible, like subependymal vascular network and some of the circumventricular organs. Thank you very much.
Thank you so much, sir, for sharing this very informative article and for clearing the anatomy so much nicely. Thank you so much, sir. And I would like to share that, sir, put an extra effort by going home to get connected and to restore our and to share his lecture with us. And it's a huge favor for us all that sir had to go an extra mile to share his lecture. Thank you so much, sir.
Thank you.
Thank you, sir. Sir, is there any questions? There's an echo issue here. I guess I need to check it. Any questions from the panel?
No.
Thank you so much, sir, again, for sharing your lecture. May I request Dr. Firoz to share his lecture on the role of CFT in MVD?
Yes, sure. Are you hearing me?
Yes. Thank you so much to
Good
Professor
evening, everybody.
Again.
I am
Yes.
Dr. Firoz Chukuru from Uzbekistan. Currently, I am the fellow. I'm doing fellowship in Fujita Health University, Bantani Hospital in cerebrovascular disease. Now I'm going to share with you the presentation about the role of computational fluid dynamics in neurovascular conflicts. So what is CFD? Computational fluid dynamics is a branch of fluid mechanics that use numerical analysis and data structures to analyze and solve problems that involve fluid flows. Neurovascular conflict involves vascular compression to the nerve, and arterial compression may contribute to the pathogenesis of trigeminal neuralgia and hemifacial spasms. Simulation of blood flow patterns is anatomically realistic models enables to analyze the hemodynamic characteristics in cerebral vascular disorders, such intracranial aneurysms, neurovascular conflicts, atherosclerosis. So why is CFT required? It's a available methods, MRI, 3D imaging, TOF MRA, SWI sequence, are static methods. And neurovascular conflict is a dynamic pathology. That's why sometimes MRI cannot identify the offending artery. Artery passes through the nearby trigeminal nerve without obvious contact, multiple vessels contacts, compressions. This is the four main parameters of computational fluid dynamics. The first one is wall pressure, is a perpendicular force. The second is wall shear stress, is a tangential force, is usually described as frictional force on the viscous blood, which can act on the endothelial cell. Streamline velocity, the third, and the last one is flow vector. Our study included 10 patients in Fujita Health University Hospital, and among them, 7 of them with trigeminal neuralgia and 3 hemifacial spasm. And during these cases were done CFD analysis to intraoperative findings. This is a video of right microvascular decompression of the patient. You can see in this video, this is a trigeminal nerve, and this is a offending artery, superior cerebral artery. Was done the interposition at 3 points. In this case, you can see the interposition with the substance of Teflon was done in this case in 3 positions, in that positions with a compression, neurovascular conflict places. Putting the Teflon between the offending artery and trigeminal nerve. Was done the ICG and intraoperative findings were compared with the CFD findings. So after comparing, correlation was found between CFD changes. This is CFD, which describes the flow, streamline flow of the offending artery, superior cerebral artery. This is a wall shear stress of this artery. This is intraoperative finding. You can see that in this case, neurovascular conflicts places in these hotspots are correlating with this place, with these hotspots in wall shear stress and in streamline flow. And this is a preoperative 3D fusion of this patient. So we can find that these parameters are correlating with each other preoperatively, intraoperatively, and in CFD changes. So high wall shear stress correlated well with, and we see intraoperative findings in 8 out of 10 cases. Streamline flow correlated in 7 out of 10 cases. Wall pressure changes and flow vector showed no positive correlations. And as a discussion, we studied other articles. For example, one of them is the article of 13 consecutive patients was done by Tema. And of the 13 patients, offending artery had high wall pressure in 12 and increased wall shear stress in 9. You can see in these cases high wall pressure and high wall shear stress. And in the contralateral, in the control artery, these parameters are low. And the next case was done by Yamada, and in this case he studied the mean wall shear stress ratio of the arterial NVC group, and he found the focal elevation of wall shear stress at the site of the NVC, which suggests that symptomatic arterial compression was identified as a unique parameter that could be the reason for this trigeminal neuralgia. And the last one is 20 symptomatic TN trigeminal neuralgia and hemifacial spasm patients. In this case, where described the wall shear stress at the proximal part. You see in this case proximal part. This is the just beginning part. This is a contact site. This is the distal part. And in this case, you can see that in the junction part, in the contact parts, there are high wall shear stresses, which high magnitude of wall shear stress along the NVC compared with the surrounding site of neurovascular conflict. According to this study, a high wall shear stress ratio, which indicates focal elevations of wall shear stress as the NVC site, at the compression site, could be the potential to identify symptomatic compressions. As a conclusions, we can say that computational flow dynamics can provide additional insight into exact location neurovascular conflict. And the hemodynamic features of the wall shear stress may play a role in the preoperative evaluation of specific areas of conflicts in patients with trigeminal neuralgia and hemifacial spasm. And of course, larger sample size and randomized analysis is required for further evaluation. Thank you very much. What's wrong?
Yes, thank you so much. There's just a little lag. Is there any question? Thank you so much, Dr. Firoz, for sharing your work. Any question from the panelists?
Actually, I have a question.
Yes, sir, please.
Okay, so very interesting presentation. I want to ask if you have normal controls. I mean, patients not suffering from trigeminal nerve pain who underwent the same analysis, just to have a negative control.
Hey, come here. Yes.
Thanks for the question, sir. Actually, recently we had one patient who had for which we studied both on right and left side.
Dr. Firoz, your connection, please. We cannot
I
hear
cannot
you.
hear.
Sorry. You have to turn off the microphone, guys.
Sir, recently we had one patient where we studied the CFD of SCA on right and as well as on left side. So patient was symptomatic on just on a right side, but his CT fusion image was very much similar on right and left side. So we did a CFD on both the sides, and the CFD was significantly different on a symptomatic side, that is on right side. And so we could compare the left and right in the same patient. So that was a very conclusive thing. And also we did a post-operative CFD after a transposition. So after pre-operative CFD and post-operative CFD we have done for the same patient. So it was also a significant changes in pre and post-operative CFD findings. So rather than a particular finding in a CFD, I think the changes which are post-operatively and pre-operatively, that can be studied further in we are planning some study like that, so that we can definitely say like these changes are definitely associated with the neurovascular conflicts.
Sure, thank you.
Now we are studying this experience pre and post-operative cases, and in the normal side and the control side and in pathologic side.
Thank you.
Thank you, sir. Is there any other question, please? Any question, or should we proceed? Okay, to our next participant, Mr. Sindhu Gautam. Will you kindly present your work for subarachnoid hemorrhage for nurses? Yes, hello, welcome. Good evening. Thank you. Thank you for joining.
I'm Sindhu from Nepal. Now I'm doing nursing fellowship in Fujita University, Vantani Hospital. USCH is a bleeding into a subarachnoid space from the cerebral artery. The most common cause of SCH is trauma. Most common cause of spontaneous SCH is aneurysm bleed, hypotensive bleed, AVM, and unknown cause. Cerebral aneurysm is an abnormal widening or ballooning of a portion of an artery due to weakening in the wall of the blood vessels. Classification of aneurysms, one morphological and location-wise: morphological, saccular, fusiform, and dissecting, and location-wise, anterior circulation and posterior circulation. Demographic details about aneurysm SCH. Incidence rate is about 6 to 8% per 100,000 persons per year. Female are more than male. Age is 5th and 6th decade, more common in Finland and Japan. Risk factors are smoking, hypertension, diabetes mellitus, old age. Pathophysiology, after SAH, bleeding into the suborganized space cause neurological deficit, hydrocephalus, headache, vomiting, and coma. Clinical features, symptoms of an unruptured cerebral aneurysm include headache, eye pain, vision deficit, eye movement deficit. And symptoms of ruptured aneurysm, initial sign is rapid onset of worst headache of my life, changes mental status such as drowsiness, motor deficit, cranial nerve deficit, and coma. Algorithm to manage SAH case. One, clinical evaluation, history of the patient, sign and symptoms, clinical grading of SAH, radiological evaluation, CT angio, DSA, confirming diagnosis, and initial management followed by the definitive treatment, surgical clipping or coiling. Clinical grading system, WFNS grading, more the grade, less the prognosis. Investigation for aneurysm, CT image, CT angiography, and DSA, all are showing the aneurysm here. SAH management protocol in emergency room, maintain AVC, control of hypertension, emergency CT scan, lumbar puncture if CT is negative, ventriculostomy, acute hydrocephalus to monitor ICP and drain the CSF if needed. Angiogram as soon as possible, careful clinical monitoring. Surgery better within 24 to 72 hours. If delayed, done after 10 to 12 days. In ICU, head elevation for 30 degree, low external stimulus, restricted vegetation, no loud noise, strictly maintain intake and output, daily weight, vitals, nothing pervoral, and IV fluid and it should be given. Medication, prophylactic anticonvulsant, analgesic, steroid, stool softener, antiemetic, calcium channel blocker, proton pump inhibitor. Clinical monitors, AVG, CVC, electrolytes, PTINR, hematocrit, urine and serum osmolality. Physiological monitors, blood pressure, CBP, ICP if ventriculostomy, and chest X-ray. Treatment option, either microsurgical clipping or endovascular coiling. Operative guide for the nurses in aneurysm surgery. Patient position depend on location of aneurysm. Image showing different position in aneurysm surgery. Place DVT prophylaxis before the surgery. Image showing the position in OR. Type of special microsurgical instruments during arachnoid dissection. These are the aneurysm clips and aneurysm clip applicator. Size of the clips should be 1.5 times of neck of the aneurysm. New advance in aneurysm surgery, intraoperative ICG flow study, use of endoscope for the better visualization. Post-operative complications, vasospasm, rebleeding, infraction, hydrocephalus, seizure, electrolyte imbalance. Nursing intervention in post-operative period. All patients should be monitored in the intensive care. A complete neurological assessment is performed regularly. All patients monitor for vitals and electrolytes. Mobilize patient as early as possible to avoid complication. Start on oral feed depending on neurological status as early as possible. Avoid any source of infection during hospital stay. Thank you.
Thank you so much, Dr. Sindhu, for sharing this very informative slide. And it is very important for the nurses indeed to know how to deal with this very common presentation. And it's very important because the timely action will be, it is like a stitch in time saves line phenomenon. Thank you so much. Is there any question? Any question, or should we proceed?
No.
Thank you so much. So I guess that Professor Liu wants to share just a line or two to basically clarify the point we had for the downstream, in the bypass. I just revised that in the Moyamo's disease, the bypass, everyone was asking about the downstream graft selection. So Dr. Liu wants to clarify it. Can we just invite Professor Liu to clarify the conclude about his presentation, sir?
Yeah, hello again. Sorry, Dr. Liao already went to the operation room because we have an emergency cases, and I'm here to just sum up like a conclusion about our presentation regarding tailored bypass based on blood flow analysis in MCA territory in Moyo patients. So usually to get a good result in direct bypass in Moyo patients, we need to consider two things. The first one is to use the downstream MCA as an anastomosing target. And it's good to emphasize that we have two types of MCA blood flow direction, like we have antegrade direction and retrograde direction. So when we say downstream, it doesn't mean that the anastomosing target should be the distal part of MCA, because in case of retrograde blood flow, that then the anastomosing target should be the proximal part, right? So this is the first thing. The second thing is to make the bypass flow and the initial flow at the same direction. Like if the initial flow in the MCA territory is antegrade, then we need to make the bypass flow the same direction. In the same direction. So by doing that, we will decrease the blood flow competition. And as we have results in our studies, we found that decreasing flow competition also decrease the possibility of doubling watershed phenomenon, as well as it lowers the risk of transient neurological deficit post-operatively. And thank you for giving me this chance to make these points clear. Thank you.
Thank you so much. Is there any questions from the participant regarding this point again? Okay, thank you so much to all our participants. Special thanks to Professor Alberto Filati, the chairman FSG Alumni Association. So thank you so much for sharing your lecture and for the extra effort today. So for us, thank you so much for the dedication in your lecture. Thank you a lot. Thank you to Dr. Lau for sharing his work, to Dr. Chandra Taj, to Dr. Gautam, to Dr. Ricardo Tanzani, to Dr. Vibhav Sharma, Dr. Firoz, and Ms. Sindhu. And I would like to request Dr. Boon Sang Liu. Sir, is he online? Will you kindly deliver your closing remarks?
Yeah, hello everybody. Yeah, can you hear me?
Yes.
Hello? Yeah, can you hear? Okay. Yes. Yeah. Actually, thank you very much for very excellent presentation, especially from all the Bantane or hospital fellows. I find those findings are very new, important, and should be shared with more. And hopefully all will appear in next publications. And also thank you to our newly elected president of the Bantane Hospital Alumni. And also I wish to share my screen here because I wish to give a few announcements. Yeah, can you all see the screen? Hello?
Nope, sir. Nope, sir. Not now.
Not now. Wait one moment. Video share screen. Screen. Okay. Can you see my screen now?
Not yet.
No.
Yeah. One moment. Yeah, it should be out now. Is there?
Wait.
Yes.
Yes.
Okay.
Yes.
Yeah. Okay. Thank you, Alberto. Yeah, I just want to show announcement on our next winter seminar, our sixth winter seminar. Dr. Satis is the secretariat, and will be held in Bantane Hospital from February 3rd to 6th next year. And the email address is written there. So hopefully more young neurosurgeons can join the workshop. It's a very interesting and important things that you can gain and from the workshop and also from the symposium. Next, also there will be a live surgery and seminar on IVR and open surgery on aneurysm. they are also talk on endoscopic surgery and also spine and skull-based surgery. This is at Hanoi in February 22nd, sorry, 21st to 23rd next year in Vietnam. And last and not least is upcoming 13th International Conference of Asian Congress of Neurological Surgeon, which will be held in Kazan, Russia in May. Hopefully all of you can join. And lastly, I would like to thank Professor Kato for her recent visit to the hospital where I work, and regards from my boss, Dato Azmin, and thank you to all who joined the webinar today.
Thank you so much, sir, for your kind invitation. That will be very helpful, and we will be televising and broadcasting it live, so that people will be able to get to know about these conferences and these very informative workshops. I again thank you, sir, and thank you all for your great participation. And I want to say a huge thanks to Professor Yoko Kato for her very kind initiatives in organizing all such very informative workshops, for all the care that she shows, all the concern that she has for the young neurological surgeons. And I'm really grateful to her, because I think that she's one wonderful neurosurgeon that has got a huge concern with this. And I guess we would like to televise any conference and any webinar that Professor Kato is involved in. It's every time it's a huge pleasure to televise any program from the ACNS. So I thank you again, and I would like to request you to keep organizing such amazing conferences and webinars. So thank you. I guess that it concludes our webinar, and if there is any suggestions or any questions, kindly share your opinion, and so that we just say goodbye to everyone and just conclude.
Thank you.
Thank you,
okay,
sir.
thank you, Professor Alberto.
Thank you, sir.
Bye-bye.
Thank you,
Thank you
sir.
to all of
Thank
you.
you, sir. Thank you, sir.
And welcome to the Fujita meeting in February, as Dr. Liu announced. Please join.
Sure, so it will be huge pleasure for me, and I will also extend this to my colleagues as well. It will be huge. I'm just looking forward, very excited. Thank you again, sir. And I think that I will also share this news on Facebook and on neurosurgical.tv. Thank you, sir. And thank you so much for your very kind information and time. Thank you so much, sir. Thank you so much,
Thank
Professor
you to all of
Boone.
you.
Thank you.
Yeah, thank you. Thank you. Thank you, everybody. Bye-bye.
Bye, sir. Bye. Bye to everyone. Thanks for the huge successful webinar. So here we conclude this webinar. We call it here. Professor John?